Hi guys, welcome to week 2 of COU 555, Diagnosis and Psychopathology. In our just kind of tangential video this week as we're talking about not just the criteria in the DSM, but the related topics. Today I want to talk a little bit about the pros and cons of diagnosis, the points for it and the points against it, as well as the process. I would like you, before I even get into my thoughts on this, as your first video response question, in just a second, to pause the video and to think about, what do you think are the reasons that diagnosis is helpful or potentially unhelpful? What do you say are the pros and the cons? You probably came in with some of those thoughts. They may have intensified or shifted since we started the class. So I want you to pause and think about, what are the pros and cons? What feelings do you have towards diagnosis as we go into this? And then I'll share with you some of my thoughts. And I imagine there'll be some overlap as well as maybe some additional pieces for you. So go ahead and pause the video, write that part out for your video response, and then come back. Okay, hopefully you're doing that. Hopefully you've done that. And here are some of my thoughts to, again, help you name and flesh out and deepen your awareness of the pros and cons of diagnosis. Because there are pros and cons, let's just be honest. You're going to learn how to do it in this class, but there are pros and cons. So, things that are helpful about diagnosis, reasons we want to do this. I'm not going to take them in order here, but one of the ones up here is that it's helpful to allay the fears of the patient. I can remember a client I had back in California when I worked for the county, who I had the opportunity to share with her. I don't always, in fact, I don't normally just share this with clients, but in her case it was appropriate. I can't remember if she asked, or I can't really remember why, but we had a conversation about the fact that I thought what she was experiencing is bipolar. That's what we would name it. It wasn't just depression, it was bipolar, and here's what this meant, right? And I can even remember getting out my whiteboard. I loved my whiteboard even back then, and drawing for her. This is what bipolar looks like. This is what people who have a diagnosis of bipolar often experience. And for her, that was an wow moment. It made her feel validated. It made her feel less crazy. It made her feel less alone, and it made her feel hopeful that maybe this didn't have to be her life forever, right? So sometimes naming what people are experiencing can be incredibly positive for them. So I want to say that's a pro of diagnosis. In addition, diagnosis is a tool we use actually sometimes to communicate with our clients, but often to communicate with one another as professionals and with the field. We can do research around, what does depression look like and what are successful treatments for it, right? What are medications that help people that have bipolar? We can do research. I can say to you, hey, have you had a client who's experienced this? What did you find helpful? Right? So this becomes a way of communicating by naming things that allows us to benefit from each other's experience and learn together as a field, versus having to reinvent the wheel every time we see a client with every clinician in every practice. And that's actually pretty cool, right? That I can learn from what people have done before with bipolar, what's worked and what hasn't. I don't necessarily have to repeat all that. I can make a treatment plan that help me make an informed decision about how to help this person. I could also tell this client with bipolar, hey, this is probably not going to go away on its own. We probably need to take some steps in order to help you manage this, right? I know that because we've done research, because I'm not having to recreate the wheel, right? So that's all really important in terms of treatment, that we're able to build on each other's work and communicate clearly about a shared, using a shared language about a common experience. This also helps us communicate with insurance and helps things get paid for. Insurance is an evolving reality. At this point in time, as I record this video, insurance pays for a lot more than they used to in relation to mental health. They still prefer it if there's an actual diagnosis, though. If you meet criteria for something in this book, they're pretty likely at this point, this didn't always used to be the case, but pretty likely to pay for therapy services. at this point, most insurances won't pay if you don't have criteria, or it'll be much more limited. I think even that is going to change. There's some movement in legislation here and there to have preventative care where you don't have to meet criteria. But at this point, it's a way to also communicate with insurance and get services paid for, which is important, right? So having names helps us predict a little bit what things will look like, know how to treat them successfully, get that paid for. These are a lot of really good benefits for learning diagnosis. Yay! Because you get to learn in this class. Lucky you. And let's acknowledge there's some potential downsides, some potential cons to diagnosis as well. So here's a few of those. Again, you may have similar ones. You may have different ones. I look forward to reviewing those responses. I wish we could do it together, but I look forward to reviewing them in the assignment. Real life doesn't always match neat categories. So even in this class, you're going to find as we do vignettes, you come up sometimes with slightly different answers because it doesn't fit perfectly. That's going to get worse when you're with real people. So we're trying to fit people in boxes and they just don't always fit, and that's frustrating. Also, we could become kind of lazy and overly simplistic and miss the whole person. None of you will do that. Please, none of you will do that. But I have worked in places where a client walks in and says, oh, I have mood swings. And the psychiatrist or clinician goes, okay, bipolar, done. Whoa, let's slow down, right? Let's really understand this person and be present with them. And first of all, not make a wrong diagnosis because we're sloppy and we're rushed. They're probably not lazy. That's not a fair term. Sloppy, rushed. Let's also not then say, oh, well, the bipolar, so that's all we're going to look at. And none of the rest of your story, your trauma, your history, your medical issues, your circumstances matter, right? So we can get too laser focused in a way that is either wrong or just too small. So that's possible if we elevate this diagnosis piece too high. We also have to be concerned about the fact that labels follow people. So if you give a 6-year-old a diagnosis in their school chart, they will still have that on their school chart when they're 18. So we just need to be aware of that and aware of the implications, especially in various settings, about the fact that labels can follow people. And that not only systems, but individuals experience that reality of labels differently. You know, I just described the client who was so relieved to have the name of bipolar, but there could also be people who have the name of bipolar and they're like, well, I can't do anything now. I can't. I'm a victim. I'm stuck with this. It dictates my life, right? So labels, right? Names of things can be really helpful and freeing, and they also can be really limiting. And we want to just be aware of both and how individuals and systems can experience them positively and also damaging in a way. Ethical issues regarding insurance billing. There can be a temptation. We talked about this a little bit last week. There can be a temptation to overstretch the truth in order to get insurance to pay for things. So we don't want to do that. Like we said, that's insurance fraud, but there can be a temptation. I was doing an evaluation recently for an adoption and thinking, okay, well, there's not a diagnosis in here for this, right? This is really, I think I gave them other counseling and I thought, ugh, is the insurance going to pay for this? I don't know. I'm still going to give it to them, but there's that, ugh, right? I have a couple I see who, the wife has actually asked me, can you give me an anxiety diagnosis so the insurance will pay for this? And I'm like, oh, okay, first of all, does she really have an anxiety diagnosis? But second of all, is that even what we're treating? Or are we doing couples work? That's, okay, there's a lot of mess there that we have to sort out, but there's the temptation, the reality that diagnoses are paid for by the insurance can kind of pull us a little bit. So there's that reality. Differential issues is just, again, that people are messy in real life and sometimes it's hard to tell what is what. You know, I mean, imagine a kid who's acting out and they're acting out big. Well, is that depression? Is that a conduct issue? Is that ADHD, right? This can get really messy in real life. And on top of all of that, as if that's not enough, there's also this question of, is diagnosis as accurate and as helpful as we think? Some people disagree. So I want to just name that. Some people don't think that diagnosis is that accurate or helpful. Let me give you a couple examples. Kinghorn says, I think Kinghorn's a psychiatrist, I'm trying to remember, says, I began to see that the standardized structured diagnosis of the DSM is intended to enable clinicians to understand patients in straightforward ways, could also be ways of not seeing what mattered most. It can be oversimplifying. We can miss the whole person. In my work with combat veterans, Kinghorn says, for instance, I began to realize that while the DSM diagnosis of PTSD had conditioned me to understand trauma as a disorder driven by fear, what many veterans struggled with most deeply was not fear, but rather guilt and shame for things done or not done in war. I began to see that psychiatry's standardized approach to diagnosis might make the work of psychiatrists more efficient, but could get in the way of understanding patients' stories in a manner that would lead to genuine healing. Right? This is that piece we just looked at. We can oversimplify, miss the whole person, miss what's really critical because we're so focused on does it fit this box, right? Kinghorn goes on. Oh, where did Kinghorn go on? In all of this, I began to see how medicine, far from being a benign force for good and healing, could serve as what the Bible refers to as a power, defined as a structure, is that right? I don't know, of life in a fallen world that while at its best a force for good, the DSM, a force for good, could just as easily obscure or hide the good and even contribute to evil. I got some typos in that quote, but you get the idea. It can be a force for good, and it can be used in a way that obscures or hides the good and even contributes to evil. Yikes. Yikes. I want to name that. I want you guys to know that. So you walk in, as you learn how to use this book, you develop competency. Again, the current version, I really got to get myself one of those, that this is a sword. This is a weapon. And you can use it in this field and in this world for good. But you need to be mindful and thoughtful because it is also possible to use this in a way that wounds, that creates evil, that misses people, that does harm. So I want to name that, and I want you guys to be have appropriate awe and respect of the power involved in diagnosis so that you can choose to use it for good. You can choose. There are some clinicians, I won't take a lot of time here, but Bessel van der Kolk, Sue Johnson, these are some pretty big names. They're like, we're done. It oversimplifies things. It misses. It ignores the underlying causes. They're done. They don't even really want to use diagnosis. That's okay. When you're at that point in your career, you can be like Bessel van der Kolk and Sue Johnson if you would like, and not use diagnosis. And also, I want to name that some people are very concerned about whether how culturally humble and culturally appropriate this book is, and that we've done that badly. So we'll talk about that more in a future week, and we'll talk about that as we go through this class. So yikes, there can be harm, and as a result, some major names are really moving away from diagnosis in their practice. That's okay. And you still are going to have to use and learn it. And I hope that with that, we figure out, you and your supervisors, all of us figure out how to use this as a powerful tool for good. I hope. And regardless of that, you kind of are going to be stuck as you're learning because you have to know how to do it to be a licensed clinician, to be a practicing clinician. You have to know how to do it to use insurance. You have to know how to do it to work in a lot of systems. So you got to learn how to use and learn it, regardless of how you feel about that. But it's okay to have big feelings about that and to keep being present with that. And again, maybe you get to a point in your career like Bessel and Sue that eventually you're like, nope, not for me. Okay, that's fine. Right now, though, you're going to have to just hold that and be mindful and be aware and try to figure out how to use it as a tool for good. Before I go into my last little piece, I would love for you to pause the video again. And your video response question number 2 is just, how is this striking you now? What's coming up? You have reflected already on what you saw as the pros and cons. Now I'm reflecting on that and naming. There's some really powerful positive stuff, and there's some really risky stuff. What's coming up for you? Where are you at with that? How do you feel about this whole diagnosis thing, or what thoughts do you have now? That's video response question 2. Feel free to pause if you need to. We'll do one more quick thing when you get back. Okay, so knowing that at least at this point in your career, you have to learn to diagnose. Just a couple quick thoughts. Morrison does a really good job of covering that. I think you guys read that last week. Oh, well, last week and this week. So that's great. So we're still learning as we go through about the diagnostic process. How do we diagnose? And I kind of alluded to this last week. And again, Morrison does a really good job. Pay attention to Morrison here in the part 1. But really what's going to happen is we first, step 1 in making a diagnosis is we gather information. We gather lots of information. We ask the client a ton of questions, and we tend to ask about everything. I ask about mood, and I ask about eating, and I ask about, sexuality, and I ask about trauma, and I ask about, and I ask about everything because I'm just collecting information. I'm going to the fridge like we talked about, and I'm like, what are the ingredients I need to pull out here? What's relevant that could go in the stew pots, the soup pots? So we're just asking about everything. Exactly what you ask, how much detail could be influenced by what modalities you use. So I might ask more about family history if I'm psychodynamic instead of CBT. But at this point, we're just asking. We're just gathering information. And you're going to gather it from the client, but depending on who the client is, you might also gather it from tests and assessments. We'll come to that at a future class. You might also gather it from parents or teachers or partners. We call those collateral when we're asking other people about the client. If you've had ethics, I think you know you need a release to get that information, but sometimes that's helpful. We're also gathering it not only by asking questions, but by observation. How is this person interacting with me? Are they acting like they're seeing things that I don't see in this room? Is it a kid acting like they can't sit still? Right? So we're gathering information primarily through this use of questions and listening to what's said and what's not said, but also through observation, through collaterals, maybe through assessments. We're gathering information. And then we take all of that, and you probably go first to the table of contents in your DSM, and you look at section 2 and all the different diagnostic categories. And you're like, okay, could there be a neurodevelopmental disorder? What do I know about those? No. Is there something psychotic? No. Okay, bipolar. Oh, maybe I need to look at that one, right? So then you after you gather the information, at this stage, you don't even know what they all mean. But like imagine in 8 weeks, you're going to go through and say 7 weeks now. Okay, it could be something in one or these, maybe bipolar or maybe depressive disorders. Those are the ones I want to look more at, right? And I'm looking first at the categories, and then I flip to that section in the DSM and I go, okay, is it major depressive disorder? No. Is it right? And I look back through. This is a reference book, but notice how you're kind of funneling. You're taking all the information, all the stuff out of the fridge that's relevant that you can find, everything. You're looking really thoroughly, and then you're putting it all in, and you're funneling. What are the possible categories? And then can we get down to more particular diagnoses? Eventually, especially as you're new at this, you might come up with a few and have to go back and ask the client more questions because you didn't ask everything you needed the first time. You didn't have enough time. That's okay. But you're funneling the information and you're trying to find what soups can you make, right? What fits best, most concisely, most accurately, just like we looked at last time. As you've already found, they never have to meet all the criteria. So just even they meet 4 out of 7 might be enough. But you're funneling the information. That's how you're making the diagnosis. As a side note, I used to literally do that, and then I'd photocopy. Okay, I think there could be GAD, there could be major depressive disorder, there could be these 5, and then I would literally take them back to the session the next week and be like, all right, I got some follow-up questions, therapeutically, clinically. And I would write on the page and check off. I don't necessarily need to do that anymore, but that's okay if at the beginning it's that much of a funneling process and kind of a back and forth. Yep, I've already talked about the assessment. Morrison, again, uses some great terms where he's talking about a similar process where you gather data, you narrow down, you pinpoint syndromes, then you get to narrow down to a few and you have a differential. So pay attention to these terms as well, and how he's using them. You begin to narrow it down, you eventually write a diagnosis, and then notice you continue to reassess. Well, we could just put a period there. You reassess because this is a snapshot in time, but also as new information arises. So it might be that 6 months from now, they don't meet criteria anymore. Or it might be 6 months from now, you find out that they have an altered personality you weren't aware of, and we need to put some more diagnoses on the table, or different ones. So we reassess as we go, as new information arises. That's how this process works. Question number 3, maybe for your video response, is just any questions about that process. Any questions? Are there any places you feel stuck, confused, as you listen to me, as you practice, as you read Morrison? Any questions? If not, that's okay, but just pause and ask yourself that for a second, and we'll make that question number 3. All right, thanks guys, have a good one.